It's now my pleasure to introduce Dr. Gottfried Schlaug, who's the director of the Music and Neuroimaging Laboratory and the Stroke Recovery Laboratory, and also the chief of the Division of Cerebrovascular Diseases at Beth Israel Medical Center and Harvard Medical School. So thank you for joining us from Boston, Gottfried.
Thank you very much for inviting me and asking me to come here and present. It's been a remarkable meeting, and it's been my dream as well to marry neurology and neuroscience and recovery, and I think we heard a lot of interesting talks already about this. So today I'm mainly going to talk about our work in aphasia, but I will touch a little bit on autism if I have enough time at the end, and I'm sort of like relying a little bit on the talk that Pam Heaton gave yesterday already on the background of autism, so I don't have to necessarily get into this. My main interests are really to examine how the brain changes, how the brain adapts, and we basically have been over the years using two model populations to do this. On one hand, there are musicians, and here we have looked at keyboards, string players, singers, and more recently drummers, although this is still in the work. Why are they interesting? That's probably not novel to you, but they begin early. They practice intensely over long periods of time. We think of them as auditory-motor athletes. They have unique abilities whose neurobiology we don't always fully understand, but they also have disabilities such as focal dystonia, overuse syndrome that are challenging for the clinicians in this field as well, that we have to consider, should consider, and that we potentially have to treat. Equally, I'm interested in patients as a clinical neurologist and how patients recover, mainly from stroke here, both in the motor system as well as in the language system. And we try to predict natural recovery processes, and we have several methods that are able to facilitate the recovery process. And then a new area of research over the last maybe 5 years or so in my lab has actually been to develop and test music interventions and test the efficacy of these interventions. And here we mainly use patients with stroke, but also those ones with auditory-motor disorders, and I'll group the nonverbal autistic children among those ones. Now, from the talks yesterday, we know that music is a very strong stimulus. It is a multi-sensory motor experience that people undergo. It makes us move, it creates emotions, it engages pleasure and reward systems, and it's really an ideal stimulus to use to get people motivated and get people move. And if music engages and changes the brain in a unique way, then the question to us was always, can it be used as an alternative vehicle to improve neurological impairments and disorders? Isabel already gave a nice talk in various aspects of singing, so I'm also relying a little bit on her, and I'm not going to go into the social and cultural aspects of singing, but I just want to review a few things. That singing, as we know, is a specialized vocal behavior that integrates auditory and sensory motor information, and that singing has shared and distinct behavioral and neural correlates with speaking, and there are numerous studies that have examined this. Here's one of our studies where, for the purpose of actually examining patients as well, we constrained our experiment as much as we could, and we also wanted to make singing as well as speaking as similar as we could. So we constrained the material that we used for singing and speaking, always using the same, and we also constrained the rate of production. And when one constrains the experiment so much, then actually singing and speaking led to a relatively similar activation pattern in the brain, activating primary as well as secondary sensory motor areas, as well as auditory, primary and secondary auditory areas. When we directly compare on a voxel by voxel basis singing with speaking, then we actually saw that singing activates slightly more regions in the left side of the brain. In the right side of the brain. Here you can see the white and the yellow indicating higher level of differences. But it, in general, was more of a bihemispheric activation pattern. There was more in singing than there was in speaking, controlling everything else, such as the volume of production, the rate of production, and the material of production. Interestingly, there was this nice little spot here in so like the middle to inferior portion of the sensory motor homunculus, which according to a lot of other studies might actually correspond to a specialized region that deals with larynx and phonation in the primary sensory motor cortex. The ability to sing is present in infancy. It does not depend on, but it can be enhanced by training. Nevertheless, we all know good singers and out-of-tune singers, or poor pitch matches, as we want to call them. And Isabel has sort of like gotten everybody interested in this by describing that first, and she certainly got us interested in this as well, and we studying the underlying neurology and neuroscience of this disorder. I'm not going to get into this today, although we have right now actually the first person that I would consider to be clearly tone deaf and who has suffered a stroke, and we're trying to actually see if we can improve that person as well with the intervention that I'm going to describe in a little bit. Singers and musicians in general are auditory motor athletes who start early, practice intensely throughout their active career. There are studies done that have actually assessed the amount of practice that singers do, and it seems like that musicians in general do from the age of 5 to 20, they probably practice roughly 10,000 hours. So just to give you an idea of how intense this training is, and the question obviously, does that lead to functional and structural adaptation of the brain? Now, when we look at this activation pattern that we had in the group of what I would call occasional singers and compare that with professional singers, and here I only show you the difference image. What do professional singers have more in activation? We can actually see there is this rim of regions of the brain that is additionally activated in professional singers. That involves regions in the brain that deal with the feedback, regions in the brain that deal with the short-term memory of auditory information, with the sensory motor encoding and the sensory motor control of this information. And it translates, and it's found not just in singing, but it also translates to regular speaking activity. I want to say here as well that although in this particular comparison we see a more of activation, there is still ongoing discussion in the literature whether or not experts in particular skills will always have more of an activation or will have less of an activation, and one definitely finds different results. In this comparison here, we found that there was more of an activation, mainly at the rims of the activation of what we saw in the occasional singers. We also looked at structure of singers and found that in a between group comparison, so this is not a causal study, this is not a longitudinal study, that there are gray matter differences, and some of these gray matter differences were actually related to years of training. And we also saw that a particular structure that we were very interested in, which is the arcuate fasciculus that Michael already alluded to, is particularly developed in professional singers. And this arcuate fasciculus, as you will see, actually connects auditory regions or auditory feedback regions with motor execution and motor planning and auditory motor mapping regions. And of interest, obviously, is that there is a reason that people can't sing in tune, although I don't have enough time to get into this, but there are structural correlates of this poor pitch singing. So we looked in more detail into this arcuate fasciculus to actually understand where are most of the differences that we see. Here we contrasted professional singers with matched instrumentalists who had a similar experience in music but played a musical instrument, and then had matched, IQ matched, as well as gender matched non-musicians. And the interesting finding here was that there was significantly more volume of the arcuate fasciculus on the left hemisphere for both the singers as well as the instrumentalists. However, the singers had much, much more volume than the other two groups. On the right hemisphere, we saw that there was a more nuanced effect, and here actually the instrumentalists as well as the singers had more volume of this arcuate fasciculus. So we actually concluded from this particular study that the left hemisphere in professional singers might actually play a more important role in the training and in the fine-tuning of the skilled auditory-motor mapping and feedback that professional singers get to. And I'll get into this a little bit more. However, the right hemisphere still shows some effects, although it may be more general musician effects that we see on the right hemisphere. Obviously, these brain effects in singers differ from overall brain effects that we saw in instrumental musicians, as you can probably see from this experiment. Here, where more hand function is examined, we found more gray matter differences in hand motor regions of the brain, but also in auditory motor regions of the brain. And in the temporal lobe, it was actually slightly inferior to where we found most of the interesting changes or differences in the singers. So, singing and music making in general activates and engages an auditory-motor network. Some people also call this an action-observation network. And I wanted to review this with you because it is actually an important aspect in understanding how facilitated recovery from aphasia might work. And in order to show you this, I'll refer to a study that has not directly to do with singing, but it has to do with mapping motor functions to auditory functions. Here we took musically naive subjects that had to learn to associate sounds on a piano keyboards, and these were short melodies of about 15 tones with particular hand actions. They had never played a musical instrument. The control condition was that they listened for an equal amount of time to melodies that contained the same notes, but they weren't associating sounds with actions. And then we did an fMRI experiment where they had to listen to these melodies, not perform any action, and then at the end, they were asked to do a 3-tone probe task, whether or not a 3-tone sample was part of the melodies that they had just listened to. When we look at functional activation pattern and look at the trained condition where they train to associate motor actions with the melodies, we get this particular pattern here of temporal and sensory motor regions. When we look at where they listen to untrained that are not associated with motor actions but equally exposed melodies, we get a slightly different pattern. And when we directly compare the trained associating motor actions with melodies with the untrained, where they have not associated, we feel that we get a network in the brain that may be particularly involved in mapping sounds to actions. And in this particular experiment here, we found that the posterior inferior frontal gyrus, or what is commonly referred to as Broca's region on the left side, was particularly active here, but also Broca homologue on the right side was particularly active. There's some other interesting findings as well in the posterior middle frontal gyrus or the premotor regions there as well. And those regions might actually play, as you will see a little bit later, a stronger role in actually mapping sounds to articulatory actions. So mapping sounds to actions involves a feed-forward and feedback loop system that is accomplished actually via the arcuate fasciculus, which is a fiber tract system that goes from the temporal lobe through the frontal lobe, and it has multiple connections in between towards the parietal lobe, towards sensory cortex, towards motor cortex, premotor cortex, and so on. And that system is involved, it has to be involved in providing auditory feedback of our vocal output and in fine mapping these vocalizations. Now, it turns out that with acquiring language, most likely, this system will become very elaborate on the left side of the brain and is less elaborate on the right side of the brain. Although when one looks at very young children, one finds actually a more symmetric organization of this system. So in some ways, this is an example of use-dependent or experience-dependent plasticity of this system already. There's some dispute in the literature whether or not this system consists just of direct fibers or indirect fibers. I actually believe it probably has direct and indirect fibers, such there are fibers from the temporal lobe to the parietal lobe and then from the parietal lobe to the frontal lobe. Most of my talk today will be just for the simplicity of it, that I will be talking about these indirect fibers that go that directly connect these regions between the temporal and the frontal lobe and vice versa. So we can actually test the function of this system, although I don't have enough time to go into detail here, but I just want to give you a flavor of what is possible today. For example, if I'm interested in interfering with sound motor mapping and see what would that actually do, I can do this with a non-invasive brain stimulation technique and temporarily inhibit particular regions in the brain, and I can then actually examine how good these individuals are at, for example, matching a particular pitch. And it turns out that these nodal points here in the inferior frontal gyrus and in the posterior superior temporal gyrus do actually play a critical role in this pitch mapping task. We did find some differential effects of the hemisphere such that blocking the left inferior frontal gyrus and blocking the right superior temporal gyrus had the most pronounced effects, but that will still have to be examined in more detail in ongoing studies. We have also interfered with auditory feedback and basically giving individual subjects the wrong feedback of their vocal output. And here, most interestingly, and it does fit a little bit more with the dominant role of the left hemisphere in vocal output control, we found that, let me see. Oops. Anyway, maybe you can see it here. There was one other picture here that there is a predominance of this activation on the left side of the brain, and it maps sort of like in the premotor cortex and the posterior middle frontal gyrus region, which seem to play a much more important role in this perturbed auditory feedback paradigm. So the question then was, for us, what role could the arcuate fasciculus or the remaining arcuate fasciculus play in an aphasic patient that has a complete disruption of the left arcuate fasciculus? Here's this particular patient seen, has a typical superior division MCA stroke that disrupts and destroys completely Broca's region, but it's not just that. That patient also has a complete disruption of the arcuate fasciculus on the left hemisphere, so that the only structure that this patient has to actually subserve and control and perceive auditory or vocal output is through the right hemisphere. Now, this patient in its most typical form, and I do agree somewhat with Isabel that we do not always find patients exactly like this, but this is sort of like the prototypical example of a patient that we like to find, and we found it. This patient has almost no ability to have an intelligent speech, but he can actually sing beautifully. And I just wanted to show this to you. So I'm asking him to sing happy birthday. Actually, say first the words of happy birthday and then sing the words of happy birthday.
O and O and O. Birthday, O. God and O.
Happy birthday to you. Can you say that again?
Call
Say that again.
Yes. O. N.
Okay. Can you sing it now?
Yes.
Happy
Birthday to you. Happy birthday to you. Happy birthday, dear Dolly. Happy birthday to you. O and O. And O.
Somehow the movie didn't play. I hope that that's not a bad sign. But anyway, you got the main message here that this patient was able to sing Happy Birthday, but couldn't actually tell us the words of that song. We always use some songs, but we actually have a more formal way to assess the dissociation between speaking and singing. So the question is really, is singing and music making, does it provide an alternative vehicle into this broken system, and could it improve neurological dysfunction and impairments? I just wanted to review very briefly for those who are not as much familiar with this. Most of the patients that I will be talking about have some form of a Broca's aphasia, which is typically a stroke that involves more frontal regions of the brain, although when people actually mapped all the lesions onto a standardized brain that would cause Broca's aphasia, actually turns out it's a huge chunk of the brain that can give you that kind of a clinical scenario. We have actually tested other aphasic disorders as well. It looks like that melodic intonation therapy works actually very well as well for conduction aphasia. It does not work for Wernicke's aphasia, mainly because their comprehension is just so impaired that they can't really follow the actual commands of the therapy. And it does also not work in people that have really complete global aphasia. So from our perspective, they have to have they need to perform at least 50% and not more on comprehension tests that we do with our patients. So in general, there are two paths to recovery from aphasia. If there is a relatively small lesion, which usually results in milder form of aphasia, recovery usually happens by recruitment of perilesional cortex. It's a very sensitive issue, and it really depends on the size of the lesion, and actually does depend also on how much the lesion impacts the arcuate fasciculus. So we have actually come up with a model where we superimpose lesions onto the arcuate fasciculus, and we can do this even in the acute stroke phase, and we can predict whether or not somebody will recover naturally or not. Is that 2 minutes? Oh my goodness. So there are large lesions, and large lesions, they really can't recover their next door neighbors, so they have to recover through the right hemisphere, through recruitment of homologue regions on the right hemisphere. Melodic intonation therapy is done, and I'll show you just a very, very brief video of this by using an extremely simple way of doing it. And I actually really like this way, first of all, because everybody in this room should be able to do it. It is universal in every country, one should be able to do it. We routinely teach the relatives of the patients how to do it. It uses 2 different pitches, 2 different durations, and it melodically intones every phrase that you want to say. So, and it uses hands. We actually use the left hand because the right hand is usually hemiparetic and spastic. So we use the left hand to tap the frequency of syllable production, and that obviously plays a big role in the treatment as well. So here's just a very short excerpt of this.
I am thirsty.
Good. Okay.
I am.
Sorry about this. I made it a little bit too short, but it actually is usually about a 3 or 4 minute process where you introduce that phrase, hum the phrase, and the patient sings it with the therapist. Then you sing it in an antiphonic way. Now at the very end, the patient actually answers a question with that particular phrase that they have learned. So what we did is an open label proof of concept trial to examine, at least like in an uncontrolled experiment, the efficacy of melodic intonation therapy. The novel things here were that as outcome measure, we chose something that was meaningful for the patient. We assessed actually their spontaneous speech. So if they would go to Starbucks and wanted to order a coffee, we would assess whether or not they would be able to do it. Almost all patients, they can learn the phrases that we teach them, which is about 500 or so phrases. They can sing them fine, they can actually speak them as well. But when you engage them in a conversation, can they actually have a conversation with you? Can they ask for directions? Can they order something? Can they express their needs? So that's what we actually assessed. And here are just two different examples of this. This is a patient that was already several years after a stroke. And here's the patient before therapy. Okay, good. And what's your first name?
Third. Vahan.
What's your last name? So he's trying very hard, but he's actually working on his middle name right now, but he couldn't get his middle name out, nor his last name. And here he is, same question. We do not practice these questions with them. They're just to show you the effects. Here he is after therapy.
My name is Vahan
Koyan. So you can see that patient, if you would ask that patient what his name is, he would actually be able to answer that question. And we have lots of questions that we ask like this, or we ask them to describe things to actually see whether or not the treatment does something in real life to them. Now, in this particular patient, what happens in the brain when we compare before to after, and here we have again the production of two-syllable phrases, rate is kept constant, we can actually see that after therapy there is more activation on the right side. In particular, there's activation of the right inferior frontal gyrus or of Broca's homologue, which we actually predict needs to be engaged because that is the new auditory-motor mapping center for this patient. It doesn't have the left Broca's region anymore. Then most interestingly to us, and I'm still a little bit skeptical myself about this, is that when we actually looked at the arcuate fasciculus, at this fiber bundle that connects temporal with frontal regions, there was quite a dramatic effect in the physical appearance of this fiber tract, which was now much more densely packed and seemed to actually reach more anterior. Now, I have to tell you, because we heard about some of the treatment studies already that are ongoing, these patients here actually had on order of 110 hours with the therapist, and we encouraged all of them to practice as much as possible at home and with their caregivers as well. So we think that this needs to be an extremely intense treatment and interaction, and it's certainly not done by the time they finish this therapy trial with us. We actually have several patients that we have followed now for several years through, and some of them we have actually treated as well to see how good can we actually make these patients over time. Can I verify the time? Okay. So I wanted to show you an extreme example of a patient. This is actually a young patient, and there is this notion obviously in the literature that young patients do seem to recover better or more. Nevertheless, it serves like as an example of what is actually possible in the brain, the more plastic the brain is. So this is actually one of the biggest strokes that I have ever seen. A very young patient was about 11 and a half years old when she came to us, and she had a complete left MCA and a PCA stroke as well. There was really nothing left anymore on this left hemisphere that could be in any way engaged in vocal output. Nevertheless, she wasn't actually so bad. She had 1 year of speech therapy when she came to us because she was not satisfied with and certainly her parents were not satisfied with how much she improved. And we actually agreed to treat her. She was an N equals 1 in our experiment, so she's not part of our actually ongoing study. But I want to give you a flavor of how good somebody can become. So here, this patient is.
Do you know what happened
before
to you
therapy?
while you had that
Yes.
stroke?
Park.
You were in the park.
Yes. And dizzy.
When was that? What year was that?
One year ago.
1 year ago.
Yeah.
All right.
So there are some phrases where she is actually relatively good, so she can say 1 year ago, but in other terms she can really only respond in single words. So comprehension was actually fairly good, which doesn't seem to be done now on the left hemisphere anymore. However, at the end of the regular trial, she had really already a nice improvement, and she's actually one of the patients that we continue to follow and episodically treat to just see how good we can make her. And here she is about 1 year after the typical trial that she went through, and now she describes that same story.
Tell me what you remember and what you know happened when you had your stroke.
I went to the Cape. And I went to a park. And I got dizzy with my friends. They're playing tag.
So you can see she's much more fluent. She can string many words together. She can actually have a normal conversation. We actually had several people just listen to her and not see her, and you wouldn't be able to, from just listening to her, tell that she has this humongous stroke. Now, what happens in her brain when we follow her over time? We actually have now about 6 time points. I'm only showing you 4 here. This is her arcuate fasciculus here over time. This is her uncinate fasciculus over time. This turns out to be her twin sister that we also were able to scan over time. Here we don't really have any changes over time, but in her case, first we see 1 year after stroke, because she rarely spoke, actually something which I would call disuse. There's actually a shrinkage of the arcuate fasciculus on the right hemisphere if you compare that to her sister. But then look at this development here over time of her only surviving arcuate fasciculus on the right hemisphere, and we see actually some similar effects, also not quite as strong, in other speech motor tracts of the brain as well. So across this proof of concept study, we actually had nice effects. All patients that were treated improved, and we have significant effects in the treatment. And when we tested patients several times at baseline, the baseline variations were small and the treatment effects were large. When we look at group imaging effects, there were 3 regions that basically stuck out. There was this inferior frontal region on the right hemisphere, there was this inferior parietal region on the right hemisphere, and the supplementary motor region. There was a little bit of activation in the right posterior temporal, but as a feedback region, that doesn't seem to change as much as some of the other regions. And we also found that there were some effects of imaging changes and treatment changes. There was a nice correlation, for example, here in the inferior frontal gyrus. We've looked at the microstructural changes, again, in more detail in the patients that had high-resolution DTI studies, and we were actually able to confirm some of the macrostructural findings that we had before without going into detail and just saving some time here. And as you know, it is still somewhat unusual to actually think that fiber tracts can remodel and can change and it can actually grow over time. However, in 2005, Randy Nudo's group actually showed this already to be happening in stroke patients. These are not human patients. These were monkeys where he made a lesion in primary motor cortex, and he was able to show that there was a rerouting that happened between premotor cortex and somatosensory cortex. And he actually also did some light microscopy and was able to actually show the rerouting of some of these fiber tracts. So how does singing help? We think that each hemisphere can support vocal output. The left hemisphere becomes more specialized over time, and there are probably numerous reasons for this. One is definitely callosal constraints. The other thing might be that the left auditory system might be more sensitive to fast components, and that the melody, the contour, the intonation, all of this emphasizes the slow components in speech or slowly modulated signals. And together with the connectedness that is trained, the chunking that is trained, that involves more right hemisphere functions, or the right hemisphere might be more sensitive to these aspects of vocal output. And then the tapping facilitates the mapping of sounds to actions. There are some wonderful fMRI experiments that have actually shown that associating hand functions with sounds or articulatory functions with sounds, or like engages this frontal system. Now, this was our proof of concept study, and in some ways it doesn't actually specifically show that melodic intonation therapy is efficacious. It shows just that an intense therapy over time is efficacious. So we had to actually come up with a control therapy that controlled for the non-melodic components of MIT. And we call this control therapy speech repetition therapy. It has some efficacy to it as well. There are some brain changes as well. There are some movies that I could have shown you that these patients do not improve as much, although they improve still somewhat. And this is actually our randomized clinical trial that is still ongoing so far. We have still 2 more patients that are actually treated until we are finished. So I hope that by the fall, we have actually finished, and we have 12 patients that are treated with MIT, 12 with SRT, and then 6 that received no treatment control, so that we can actually, hopefully, really assess the efficacy against a control intervention of this treatment. Here are the overall group effects so far, and you can actually see that as both groups change over time, and our task will be to actually see, is there really a differential effect of melodic intonation therapy? We have other ongoing studies to see if we can facilitate this improvement. Since we have particular regions in the brain that show changes, we can actually target these regions in the brain with non-invasive brain stimulation. That has already done and published. We also have web-based training available. We have training that runs on mobile devices so that we can actually give these patients an intense experience as much as possible. And we have an ongoing study where we assess the predictive value of singing and speaking in the acute phase of stroke to see how much that it would actually predict outcome of stroke and whether or not we can identify patients that would be better suited for this kind of intervention than others. Now let me just maybe 3 minutes, if I could, do on 2. On nonverbal autism. Now this was triggered actually by people who had seen videos of these patients. I was not doing any autism research before, but the thought was that kids who don't have speech, who don't speak, might be somewhat similar to stroke patients that don't speak. And the thought was, would an intervention such as melodic intonation therapy work for these children as well? It turns out that autism is on the rise. I don't have to talk about the predominant features of autism, but it turns out, as Pam Heaton already yesterday said, there are 30% of individuals with autism that are nonverbal, that don't speak. Most of them will never acquire language. There's hardly any research on this population because those are the most difficult individuals. And there certainly is no gold standard for even assessing treatment effects in these patients. So we came up with an intervention which we actually call auditory-motor mapping training, or to just continue with what Michael Talp was doing, AMMT, that uses a form of hand activity and vocal output to engage this vocal output system of the children, which they have, but they don't use at all or don't use as much. Unfortunately, I have to rush a little bit through this, but I hope I can give you a flavor of what this will actually do. We have again done a proof of concept trial where we had multiple baseline assessments and then tested the efficacy of just this treatment over time. And here is actually our second patient that we did, almost 5-year-old child. Here he is at baseline, had no vocal output.
Misha, look, what's your name? My name is Misha.
And here he is after his first session.
Hello. Hello.
Okay, wait, you have to watch. Yeah.
Hello.
You should just sit in the chair. Just sit in the chair.
If you have questions about the treatment, I can go into this a little bit later. Anyway, we didn't get any verbal output for about 10 sessions. And then at the 12 sessions, he does this.
It's time for say it louder.
You can imagine how surprised the parents were because they had never actually heard his voice before. So here he is after 40 sessions.
What is your name?
My name is
Good.
And it generalizes to other patients. So far, of the patients that we have enrolled, we have seen this effect in all of them. We have published actually this first trial already. And now, again, we have come up with a control intervention to actually prove that it is AMMT and not something else. So the control intervention doesn't have some of the actions that AMMT has, and we couldn't find any significant effect over time in this control intervention. Now, we were actually also interested to find out, is there something in the brain that would not allow them to speak? So one of the structures, obviously, is the arcuate fasciculus. And it turns out they do have an arcuate fasciculus, but their arcuate fasciculus is definitely dysmorphic, disorganized, is not as big. And one of our tasks is obviously to try and see whether or not we can train this arcuate fasciculus to do more of what it is supposed to do. Obviously, this is only one of the many abnormalities that one would find in an autistic brain. So I think I've gone through all of this. I think that I do want to point out is that if you really want to retrain a stroke patient, so even a non-verbal autistic child, that has to be a very intense and very long-term process. Right now we're testing this with 40 sessions or with 75 sessions, but I would love to go for years to actually see how much can we improve these individuals. And we found that long-term and long-lasting speech outcome improvement is related to structural changes in the brain. If you want to know more, you can go to our website and read about this. And I certainly want to acknowledge the grant support that we had. Otherwise, it would have not been possible to do this. Thank you very much.
Thank you so much, Gottfried. I'm glad we let you show the autism component because it was amazing and just really compelling for all of us. As Dr. Chamali comes up, questions for Dr. Schlaug? Take one or two real quick ones.
So the tractography that you're doing on the arcuate fasciculus is quite impressive, but I guess it's right here on your side. It's a little hard to believe that it's really reflecting that much actual axon growth. So you think that these are just inactive axons that can display activity, or whether that tractography is?
So I'm not sure, and I probably don't think that those are new axons, but I think what is likely is that we will have a lot of axon collaterals that will actually show up. So if you look at the microstructure of this tract, you will actually see that very significant increase, for example, in radial diffusivity, which means that the arcuate fascicle establishes many more connections and probably has more input from parietal regions, somatosensory regions, and frontal regions. Also, the myelinization of that tract actually increases as well as a function of training. So yes, I want to be very careful in interpreting this, but we have seen that now in almost every patient, you do need to have very high resolution imaging to actually find this. So I do feel something changes, although at this point it's more like an hypothesis of what it exactly is that changes there, but something does change.
One more question, Lisa?
Do you have any, this is taking it 2 steps forward, but seeing that there's arcuate fasciculus development of the left and the right in children who are musicians, do you have any studies of people who've had strokes who are musicians, and is there any difference in the response?
If you guys know of any physician, any musician that has really suffered a stroke and has a Broca's aphasia, I would really love to see them and treat them. It is very rare, and I'm not 100% sure why this is so rare. Something in me makes me believe that making music is neuroprotective. But it is just something that is rare. I'm pretty sure they're out there, but I haven't actually seen somebody who I would consider to be, you know, a highly active or a strong practicing musician that actually had suffered then a stroke and had recovered. There are a few cases in the literature where people have looked at musicians, and it looks like from just single cases as if recovery potential is higher, which would actually, I think, fit nicely with the imaging data.
Gottfried, can I ask a quick question following up with Lisa then? All of the imaging studies we've seen, fMRIs, and all of these are sort of functional brain maps of the neuronal networks. But what about the vascular networks, and do they change as well? So for instance, does a singer who I would imagine have a very enhanced vascular network in the brain, is that maybe why there's some protective activity versus strokes? Are you remodeling the vascular network as well as the neural networks? I would think you'd have to be.
So actually, some of the first studies that dealt with structural plasticity in the brain, they actually showed that there was a significant upregulation of capillaries as one measure of structural plasticity, and also a significant upregulation of glial cells. So those were the first structures that were shown to actually change in response to long-term skill training. So yes, there has to be more vasculature to actually support the changes in the neural structures.